All right, welcome everyone. Today we're going to talk about inflammatory bowel disease, one of the important topics for residents as well as for practicing pathologists. So I think it's worthy of looking into, and we should see how we can tackle these things. So let's start off with a question. This is how I always like to start any session because it gets everyone involved. Let me read out the question for you. Let's not waste time in allowing you to read and then find out. So we have a 35-year-old woman with 6 to 7 bouts of diarrhea with bleeding since 1 month. She has been having similar episodes of diarrhea since 5 years, which characteristically subside on their own, only to recur again after a few weeks. Her food habits are regular and she has no habits of drinking alcohol or smoking. She complains of abdominal pain and the CT scan shows no significant abnormality. Colonoscopy reveals multiple ulcers along the polypoid regions of her rectum. One of the ulcers is biopsied. Histopathology reveals a superficial ulcer in the mucosa and the submucosa covered by an acute inflammatory exudate. The edges of the ulcers are undermined and the colonic crypts of Lieberkühn contain collections of neutrophils. One of the extraintestinal manifestations of this condition that is commonly seen would be which of the following? Now, I would allow you to answer this. We have these options: pericarditis, hyperuricemia, gallstones, kidney stones, sclerosing cholangitis, and thyroiditis. And whoever wants to answer can unmute and answer. Or you can put it in the chat box. So we have two answers already. I'm not going to dwell too much on these things. Once the recording is done, you can obviously find out. But I must say that almost everyone is picking option E, which is sclerosing cholangitis, which is the correct answer. Good. So sclerosing cholangitis is one of the complications of ulcerative colitis. And this is how it looks on X-ray. You can see strictures of the intrahepatic bile duct. So cholangitis means something that affects the bile duct. Itis means inflammation. Cholangitis means inflammation of the bile duct. And sclerosing means because of repeated inflammation, there is sclerosis or fibrosis, which leads to a stricture. And proximal to the stricture, you will get dilatation. So the correct diagnosis is sclerosing cholangitis. And what I need to tell you here is that ulcerative colitis as well as Crohn's disease, they have many extra intestinal manifestations. And these could be in the form of arthritis, uveitis, after stomatitis, and skin manifestations. Now, primary sclerosing cholangitis is also an extraintestinal manifestation, usually seen in ulcerative colitis more than what it is seen in Crohn's. So this is caused by progressive chronic inflammation and scarring of the bile ducts. The others are not so relevant, so I'm going to skip it. So that was just an introductory question to just get your juices flowing. But this is the real introduction. Now, between Crohn's disease and ulcerative colitis, you will see a lot of common features, which can be good in a way, but they can also be confounding factors. So what are those common features? They both have to be idiopathic. They cannot be secondary to anything. If it is secondary to something, then you will not call it as inflammatory bowel disease. It should have a component of chronic inflammation. There is a part of IBD which also shows acute inflammation, but it is the chronicity which actually defines inflammatory bowel diseases, then you would label them as IBD. Diarrhea is a constant with both types of. So we are going to talk of these two conditions as the inflammatory bowel diseases, Crohn's disease and ulcerative colitis. Both of them will present with diarrhea, abdominal pain, bleeding per rectum. Now, this is more with ulcerative colitis compared to Crohn's disease because ulcerative colitis generally, not generally, always involves the rectum. With Crohn's, it may or it may not. And because of the chronic diarrhea, there is weight loss, one of the prominent presenting features. Extra-intestinal manifestations are another hallmark of inflammatory bowel diseases, and these include joint pains, would be in the form of arthritis, spondylitis, sacroiliitis, whatever. Skin could show up as pyoderma gangrenosum, erythema nodosum. So there are many of these that can come up. Ophthalmic manifestations could be episcleritis or uveitis. Stomatitis is very, very common. Aphthous stomatitis, aphthous ulcers are very common. Kidney stones are very common, more with Crohn's disease than with ulcerative colitis. Gallstones, again, part of the Crohn's disease story. And then we just saw primary sclerosing cholangitis, which is more common in ulcerative colitis. Now, how do you diagnose inflammatory bowel disease? You do a barium enema, you do endoscopy, which has become the mainstay so far as the clinicians are concerned. And once you have the endoscopic biopsy, you have to diagnose it on histology. You don't generally want to biopsy Crohn's disease for various reasons. We'll see what those reasons are, but ulcerative colitis is very easy to biopsy, and it's also very easy to diagnose. Crohn's is also easy to diagnose, but it doesn't heal. So as a pathologist, now we are turning after this very basic introduction, you are pathologists, and you should be asking these questions whenever you receive an endoscopic biopsy to rule out inflammatory bowel disease. Does the patient have suspected new IBD, or is it a long-standing treated IBD? Because the histologic features will be different for both of them. These will show very raw features, and these will be mostly chronic and sclerosed and all those kind of things. If new, what are the symptoms and what is their duration? Is the patient receiving any kind of medications? So these are the questions you should ask the clinician or the house officer or whoever you're dealing with, the endoscopist. What are the endoscopic appearances? Please make it a habit to ask for request for endoscopic appearances whenever you're dealing with any type of endoscopic biopsy, whether it's in the GI tract or the GU tract or wherever else. What is the distribution? We'll see how both of them are different in terms of distribution across the gut. Crohn's has a different distribution versus ulcerative colitis. So you need to know, because that gives a very good marker for you to understand whether you can start thinking of Crohn's or ulcerative colitis. Is there an evidence of previous bowel surgery? Does the patient have any diverticula? Because diverticulae are one of the differential diagnoses for IBD. So you need to get hold of that. Are the lesions raised or are they polypoid in appearance? How do they look? And what is the provisional diagnosis of the endoscopist? So before you start looking at the biopsy, you should have these questions in mind. If not, you know that you may not be able to get answers from the endoscopist to all the questions immediately, but you should have them in mind. If required, you can ask. Now, this is the distribution of ulcerative colitis versus Crohn's disease. Now, this is called as the Montreal classification. Now, one very important feature that you should always remember is that irrespective of what type, there is a proctitis variant, there is a left-sided ulcerative colitis, and there can be extensive colitis. Irrespective of everything, the The rectum is always involved in ulcerative colitis. Never forget that. The rectum is definitely involved in every single case of ulcerative colitis. Whereas that is not the case with Crohn disease. The Crohn disease can basically affect everything from the mouth to the anus, although there are preferred areas of distribution, like what you can see here, the terminal ileum, the colon, which is called L2, the ileocolon, the junction, and then the upper GI tract. So there are these 4 variants for Crohn disease. There are these 3 variants for ulcerative colitis. This is called as the Montreal classification. So you should know about these. So you can see that Crohn's disease is more widely distributed, while as ulcerative colitis is basically restricted to the colon. Now, this does not mean that ulcerative colitis cannot affect the other parts of the intestine or the gut. It can, but predominantly, as I said, the rectum is definitely going to be involved, and the other parts can be involved, but not as much as Crohn's. Crohn's is like more widespread in terms of distribution. So again, this is another image of the same thing where I'm showing you the importance of involvement of the rectum in ulcerative colitis versus Crohn's. The other thing is that these are patchy in distribution. These are more continuous in terms of distribution. Now again, this is very general. Crohn's disease or ulcerative colitis, it's not specific to either of them. Their distribution can be diffuse. Now, this is a mucosal lining, okay? This is a schematic of a mucosal lining. You know how it looks like a test tube. These are the normal crypts are generally described as very straight and they look like test tubes. However, the entire mucosa can be involved, so it can be diffuse involvement. It could be patchy in terms of some villi being involved at different sites. And then in some areas, the muscularis propria or something can be involved. It can also be focal, small patches here and there. So there are various types of distribution that you need to know. And now basically based on what we saw in this slide and the earlier slide, you have to keep all your options open. Anything can happen. It can affect any part, anywhere. So you cannot just be very sure that this has to be ulcerative colitis or this has to be Crohn's unless you really verify stuff. Now, the most important takeaway that you have to remember is that Crohn's disease is a transmural condition. It affects all. This is another way of distribution that you can understand. Crohn's involve all the layers of the gut. It's transmural. And that's a problem because it will penetrate this and it will start forming fistulae, which is perhaps the most dreaded complication of Crohn's disease. While as ulcerative colitis basically attacks the mucosa. It attacks the mucosa, it destroys the mucosa, it crushes the mucosa, it does everything, all the damage it can to the mucosa. So the chances of dysplasia happening in the mucosa and then subsequently malignancy is more often with ulcerative colitis versus a Crohn's where a fistula formation is very common, and once a fistula is formed, it rarely heals. It's impossible to heal a fistula from Crohn's disease, which is one of the reasons why you should not take a transmural biopsy of Crohn's as much as possible. You should not be in a hurry to take a transmural biopsy. The only indication for a transmural biopsy is if there is actually a fistula that has already occurred. And if you want to resect that part, that's the only indication where you can get the whole thing out. Otherwise, you should do just an endoscopic superficial biopsy as much as you can. Now, this is perhaps, this is very important and also perhaps the most important differentiating feature between Crohn's and ulcerative colitis, especially for residents. And this is what is tested very frequently. So you should know this. It's very high yield if you are a resident. And this is dependent on some immunologic phenomena. Now let us look at this Crohn's disease. Now it's very difficult to pronounce this word in particular, so let me pronounce it for you. It's called anti-Saccharomyces cerevisiae. Remember how it is pronounced? It's pronounced as cerevisiae. Antibodies positive. In short, you call it as ASCA positive, but it is anti-Saccharomyces cerevisiae antibodies. Now, what is this Saccharomyces cerevisiae? Now, this is nothing but a commensal bacteria that is present in the gut. You know that there are these Saccharomyces species present as commensals in the gut, but sometimes you start getting these anti-Saccharomyces antibodies, and that is found in Crohn's. It is not found in ulcerative colitis. Instead, you get P ANCA positive. So this is a big difference, and this is often tested in your exams if you're appearing for any kind of exam. So please remember this. Now, Crohn's disease, the pathophysiology is mediated through Th1 cells, which activate the macrophages, and therefore, what you see in Crohn's disease is a granuloma. Versus, if you look at ulcerative colitis, it is mediated by Th2 cells, which will lead to antibody formation, but there is no granuloma formation. So there is a basic difference. Crohn's will have granulomas most of the time, while ulcerative colitis is characterized by the formation of an ulcer. Autophagy genes are involved. There is one called as NOD2, nuclear oligo domain 2, oligomerization domain 2. Now, this is part of the innate immunity apparatus, which helps in the process of autophagy. Autophagy is, you know what is autophagy? It's basically when the self organelles are phagocytosed with the help of a lysosomal hydrolase, and an autolysosome is formed. So NOD2 is associated with Crohn's disease. So that is something you have to remember. Well, as here, the extracellular matrix genes are involved. They inhibit matrix metalloproteinase. This is the pathophysiology of Crohn's versus ulcerative colitis. Now, this is very important. This is very important. And these are the things that are tested. Now, again, as a pathologist, you should be aware of the histologic features that you will encounter in inflammatory bowel disease. We'll see one histologic feature after the other, and please pay attention to what is going to come. We can divide the histologic features as architectural changes, which will include irregular villiform mucosal surface. I'm going to show you images of each of these histology images. Crypt distortion, crypt atrophy. The second change after architectural, these are the broad sweeping changes, the architectural changes. Then we have chronic inflammation of the lamina propria. As I said, there can be acute inflammation, but chronic is what interests us more. And that is in the form of basal plasmacytosis. So you have plasmacytes. I'll show you again histologic images. Increase in the lymphocytes in the lamina propria. And these are non-aggregated. They're not clustered. On the other hand, you can actually also get lymphoid follicles or lymphoid aggregates. And as I said, we do get acute inflammation in the form of cryptitis, crypt abscesses, and ulceration. This is more specific to ulcerative colitis compared to Crohn's disease. Then you have epithelial changes where there is depletion of the epithelial mucin. Then there is Paneth cell metaplasia. You can find granulomas, giant cells. And then there are miscellaneous changes where you get an increase in the number of crypt epithelial apoptotic bodies. There's an increase in the density of epithelial lymphocytes. There is acute inflammation in the lamina propria, eosinophils, fibrosis or hypocell. These are not specific. But the reason I'm segregating these things is because as a pathologist, as a resident, when you approach a slide, this should be the sequence. First, look at the architecture. Look at the villi. Start from the bottom, start from the top, start from the mucosal surface, and then come downwards. Look at the broad um, features at 4x or 2x, whatever you have. Identify the broad architectural changes, then go high magnification. Look for chronic inflammation, in particular plasmacytosis. This is very crucial. Then look for cryptitis, crypt abscesses. And then finally, you must also look for epithelial changes, in particular Paneth cell metaplasia. We'll see images of all of these. Now, before I show you the image, let us look at these illustrations because they simplify everything. So this is the normal colon with the straight crypts that we see, the test tube kind of appearance that they see. Now, with IBD, you are going to see these three changes. There is atrophy of the crypt, which means the height of the crypt is decreased. Sometimes there is complete loss, which means there is no lumen. It is completely blocked off. And the third thing is distortion of the crypts, which can be in the form of branching. So these are the three important things that you see in IBD, but more in ulcerative colitis. So this is what I was telling you. These are the architectural changes of crypt distortion, crypt atrophy. So you can see here that there is a branching. You can see the branching here, right? You can see that the crypt has been shortened. Again, this is one of the second thing. This is crypt atrophy. This is crypt distortion. You can see that they are almost fused. It is definitely distorted. This is also fused. This is distorted. This is shortened. So this is feature number one. Architectural changes, crypt distortion, and crypt atrophy. Very, very important, especially in ulcerative colitis. The second change, again, normal colon for your reference. And then you have crypt abscess, where the crypts are filled with neutrophils. And then there is also cryptitis, which means the neutrophils also invade the cell cytoplasm, the cell wall, and it also surrounds the crypts. So we'll see histologic images. The reason is I don't want you to forget. These might look very easy because they are illustrations, but you should be able to identify them in histologic images. See how the neutrophils have actually penetrated the walls of the crypts or the glands. So this is cryptitis. And inside the lumen, you have an accumulation of neutrophils. So this is a crypt abscess. This is cryptitis. Crypt inflammation, crypt abscess. Again, a case of ulcerative colitis. I think you should try to recall these images as much as you can when you see them. Now, the other thing that you should immediately grasp here is that this is a very high power image. So right from scanner view, you have to go up as much as you can in terms of magnification if you have to identify such lesions. The third thing I told you already was about Paneth cell metaplasia. So this is the location at the base of the crypts is where the Paneth cells are located. Now you do see Paneth cells mostly in the small intestines. You also see a few of them in the large intestine. But if you see them in the large intestine, especially after the splenic flexure, then it indicates ulcerative colitis in its chronic phase. So it indicates chronicity. And these are very dramatic cells which can be identified very easily. See, look at these Paneth cells, these pink cells. Look at these Paneth cells. So what is the function of these Paneth cells? Normally, it has two functions. One is that they contain, you can see these granules, they contain certain chemicals that can destroy harmful bacteria. So they are like the antibiotics of the gut. beyond the stomach. So Paneth cells, that is role number one. The second thing is that they also function as stem cells, and they give rise to new cells once the old cells are shed off, or they cause regeneration. But getting them in the colon is really a very spectacular finding. Now, again, if you have to notice these Paneth cells, you have to really go high power. So when you are diagnosing a case of IBD, never ever give it unless you take a look under the high power mag. That is essential. The next one is to look at lymphoplasmacytosis. Again, beneath the crypts, you will see collections of not just lymphocytes, but more importantly, plasma cells. So getting hold of plasma cells is again a very good indicator of IBD. We will see histopathology of this. You can see that this is a gland. You can see plenty of plasmacytes here. Can you appreciate them? You can see a lot of them actually everywhere. There are plenty of plasma cells. There are also lymphocytes. So these are lymphoplasmacytic infiltrates. You can see another plasma cell. So getting them beneath the crypts is a very, very important sign. So what I'm doing right now is the first, in the earlier slide, I had enumerated the sequence with which you should start looking at this slide. I'm trying to tell you the approach. More than being able to make a diagnosis, you should learn the approach to making a diagnosis so that you don't miss anything. As I said, start with the mucosa, look at the architecture, look at the crypts, distortion, crypt, abscesses, then come down to the Paneth cells, and then look at the lamina propria. You'll be able to see a lot of these plasmacytes as well as lymphocytes. Then in the case of Crohn's disease, the lymphoplasmacytes are replaced by epithelioid cells. These are histiocytes, and you can see sometimes well-formed granulomas, or sometimes you can see ill-formed granulomas. The basic difference is when we talk of plasma cells, we are talking of B cells. Whereas when we are talking of epithelioid histiocytes, you are looking at a T cell response, you are looking at TNF alpha, all those kind of things. So this is basically a granuloma. It's a focal collection of epithelioid histiocytes. You can see the epithelioid cells. You can see a larger, there are plenty of epithelioid cells. This is a classic epithelioid cell. They describe epithelioid cells as a slipper-shaped cell, flip-flops. That's how it looks. So you can see a bunch of these. It's very easy to diagnose a granuloma, I think, for you. It's taught very early on in your PG curriculum. But what you should also observe is that they are non-caseating granulomas. So this is induced by Th1, T helper cell type 1, which induces the formation of a granuloma with the help of TNF alpha. The other finding, and again, this is going to be more in the case of ulcerative colitis, because it causes ulceration. You can also notice how it's just a superficial ulcer. It's not a transmural. It's not transmural. It's not extending right up to here. It's very superficial. So this could be more of an ulcerative colitis. And this will be filled with neutrophils. So this is a case. So these are superficial ulcers limited to the mucosa and submucosa only. Therefore, unless it penetrates the muscle coats, there can be no fissures or fistulas, fibrosis, or strictures. So what that means is ulcerative colitis will not manifest as in the form of fistulas or fissures or fibrosis or strictures as against Crohn disease. However, it can go up to the level of the muscularis propria and damage the ganglion cells, the myenteric plexus in particular, and cause what is called as the toxic megacolon. We'll see some images as we go along. But remember these basic differences. You can see a good crypt abscess here. See this. You can see it's filled with neutrophils. Now, continuing with this again, you can see that this time we are talking of lymphocytic infiltration. The last time we saw was lymphoplasmacytic, mostly plasma cells was what interested us. But here you can also see the distortion of the crypts. You can see that there is shortening of the crypts, again, another case of crypt atrophy. So the reason I'm showing you this, I mean, it might look like a repeat of what I showed you earlier, but these images can tell you how variable the picture can be. Every slide is going to be different. You have to be really very sensitive and very alert to be able to make a good diagnosis. Even the smallest change should not escape your eye. See, again, you can see crypt atrophy and crypt distortion. Now, this is branching. We had spoken about branching. You can see some beautiful branching here. Again, a case of ulcerative colitis, and the crypt is definitely shortened. It's not, the usual size should be like this. So there is shortening of the crypt. And again, you can also see fibrosis here. So this seems to be heading towards a chronicity kind of situation. The villi that you see are irregular. Another change which I had mentioned right on, so far as the architectural changes were concerned. You can see irregular villiform. You can see that it is twisted. It's not the regular villus that you would expect in a normal bowel. Lymphocytes in the lamina propria, plenty of them. You can see plenty of lymphocytes in the mucosa. And again, you can see distortion. And interestingly, you can actually see what are these? These are neutrophils which are getting inside the wall, inside the glands. So this is cryptitis. Again, something that you should note. For this, you will need high power magnification and a very keen eye, a very vigilant eye. So if we have to summarize the most reliable histologic features, then these are the ones. You should look for basal plasmacytosis. You should look for abnormal architecture for sure. Crypt distortion, crypt atrophy, and an irregular mucosal surface. These are almost like mandatory. I would like to add Paneth cell here, but Paneth cells, however dramatic it seems, may not be visible in all biopsies because a very small sample is usually taken. They may not hit the Paneth cells, and that should not misguide you. So try to keep your diagnostic criteria to the minimum, but compelling enough to be able to convince yourself as well as the endoscopist. So with these as the general features for IBD, irrespective of whether it's Crohn's or ulcerative colitis, I told you there are many overlapping features. It's very difficult to differentiate many times. Crohn's disease from ulcerative colitis, they are not watertight compartments. There is plenty of overlap, plenty of confusion that can come in. So you have to keep your head on your shoulders and take a very proper look and make sure that you get to the right diagnosis. Now, if you look at the textbook kind of picture of Crohn's, this is how it looks. Now, if this is a normal intestine, one of the features of Crohn's disease is that there is wrapping of fat around the intestines. Now, this is because the first thing is there is thickening of the wall, and most importantly, because this wall fissures or it converts into a fistula, it breaks open this part of the wall and it spills out. So in order to help the process of healing or the natural process of healing that our body provides is to wrap the fat around these fissured areas. So that kind of gives like a band-aid kind of help to the broken intestinal wall, but we don't know how much. But this is a very characteristic feature. Fat wrapping, if they mention in your exams or wherever, you should know that they're talking of Crohn's disease. Again, there is this intestinal surface which is very characteristic, and I'm sure you have read about this. It's called as the cobblestone appearance. We'll see how that looks. But again, endoscopy can show these aphthous ulcers in IBD. Aphthous means they are small, they are shallow, as you can see. They can occur anywhere, again, from the mouth to the anus. They can be present everywhere, but it is a good indicator clinically to start thinking of Crohn disease in particular. So this is the cobblestone appearance. Now, as I said, there are skip lesions in Crohn disease. So you have a segment of normal mucosa here, and then you have this cobblestone appearance. So cobblestones are basically pavement. If you have traveled to smaller towns, or if you have traveled to Europe in particular, the roads are all paved with cobblestones. So you can see a similar appearance here. If you see, it's a very classic cobblestone appearance. If you look at these areas, classic cobblestone appearance. Now, I told you the dreaded complication of Crohn disease is that it can come out as a fistula through the skin. This is one. Then it can create anal fissures, or it can form pus around the anus and cause an anal abscess. So these are very difficult to treat, very, very difficult. And this is a transmural fissure which is cutting through like a knife. You can see even here that it is a very sharp edged lesion. So it's very easy to identify it on scanner view. So you should be vigilant about all these things. Now, this is the transmural inflammation. Although it is low power, the reason it's transmural is because you can see these dark areas here. All of these are lymphocytes. And you can see hyperplastic lymphoid follicles here. So this means that it is going beyond just the mucosa. So this is transmural. This is one of the reasons why it does not heal very quickly. Now, these are the non-caseating granulomas. It's a very commonly used picture. It's a very popular image, but a very beautiful image. I could not resist using it. So you can again see these very classic slipper-like epithelioid cells. Not a big deal diagnosing. This is a classic slipper cell for you. Looks like you're flip-flopped. So this is again Crohn's disease. Now, because of the transmural inflammation, what happens is there is fibrosis, and that leads to stricture formation. Now, this is a complication of Crohn's disease, and you will see a typical string sign on barium contrast study, which means at the level of the stricture, the dye does not pass and only trickles down and causes what is called as a string sign. Now, this could be another indication for doing a surgery here and getting rid of the structure. Otherwise, there are very few indications for surgery in Crohn's disease versus ulcerative colitis. Since the rectum is always involved, if you're able to diagnose quickly, just remove that part of the involved rectum or sigmoid colon, and the patient can be completely cured. But with Crohn's, you rarely can cure the patient. Now, there is this very interesting phenomenon called as pseudo-pyloric metaplasia. What happens is repeated cycles of crypt destruction and regeneration. They lead to crypt distortion, and they look like pyloric glands. As you can see here very clearly, they look like pyloric glands, but they do not function like that. They don't have any of the functions. So it's called as pseudo-pyloric metaplasia. Not a very common finding. This is not seen in ulcerative colitis. And even in the case of Crohn's disease, there are better and simpler ways to diagnose this. But again, as you become more and more senior, you start noticing these smaller things, the nuances, and you just get better at the process of diagnosing. So that was about Crohn's. This is ulcerative colitis. Again, we are looking at the distribution. Rectum is always involved. Now you see pseudopolyps here versus the cobblestone appearance that you saw in Crohn disease. Here you are going to look at pseudopolyps. Now what are they? Pseudopolyps are nothing. They're called pseudo because they're not real polyps. This is not a real polyp. It's actually that there is an ulcer here. And because there is an ulcer, another ulcer here, the intervening area looks like a polyp. So that's why it's called as a pseudopolyp. The real deal is the ulcer. And what remains is the polypoid appearance, which is called as a pseudopolyp. I hope I'm making sense. So this is why it's called as a pseudopolyp. Now, as the pseudopolyp grows, which means as the ulcer expands, see it is going deeper inside here. It's going deeper on this side as well. The mucosa from the two adjacent polyps, they start bending and meeting each other, and there is eventually bridging of the mucosa. So this is a very classic phenomena where you have a pseudopolyp with bridging of the mucosa, which is also seen on endoscopy. So this is a classic mucosal bridge that you see in ulcerative colitis, a very interesting phenomenon. This is not a real polyp, it's a pseudopolyp because of the ulcer. As I said, the ulcers are very superficial. You can see these bleeding ulcers here. This is a very classic bleeding ulcer. And there are multiple bleeding ulcers, I mean, everywhere. You can see so many ulcers. Sea of ulcers, as they call it in ulcerative colitis. Toxic megacolon, you can see this entire thing looking like a lead pipe. You don't see the hostrations. There are usually these hostrations, right? This is how it should be. This is how it should look. The tinea coli and the hostrations, this is what it would be normally. But now it's no longer normal. So it looks like a lead pipe. And that's because, as I said, the ganglion cells, especially of the myenteric plexus, are damaged. And that leads to toxic megacolon. Now, when you report an ulcerative colitis, you have to grade the activity. It's not always that you get all the features. Sometimes they are inactive, they are quiet, and that is understood if there are no neutrophils found. Sometimes it's mild if less than 50% of them are showing activity. Moderate is more than 50, and this is where you start getting crypt abscesses. So unless it hits the moderate grade, you don't even see the crypt abscesses. So the challenge for a pathologist is to diagnose ulcerative colitis in these two stages, where you don't get the telltale signs of ulcerative colitis. You have to be very, very vigilant. You have to look for all those listed criteria, starting from the architecture right up to the lymphoplasmacytic infiltration, and then the Paneth cell hyperplasias and plasmacytes. And then if it is severe, then of course it becomes easy. But otherwise, it's never as easy as it looks. Now, this is one area which, although you are a pathologist, you should know, because most of the patients that come to you will be partially treated, and you should know what management is being given, because that impacts the outcomes. It also impacts the way you diagnose it. You should know that if it's treated, you're going to see some different changes. Now, the easy part is the treatment itself. All the treatments are derivatives of 5-alpha salicylic acid. Salicylates, they are basically, if you recall your pharmacology, all salicylates are anti-inflammatory drugs. So what we are going to do here is we are talking of inflammatory bowel disease. So we are going to look at anti-inflammatories. Now, these 5 alpha salicylate derivatives are called mesalamine derivatives. Now, it's very easy to remember that there is one type of ASA. A stands for alpha salicylic acid. So there's one called as pent ASA. Pent means it works in, it's easy to remember. It's a kind of a mnemonic. If you are interested in mnemonics, if that's how things can be recalled by you, then use this. Pent ASA means it works on all 5 parts of the bowel: stomach, duodenum, jejunum, ileum, and colon. We know that with ulcerative colitis, you typically get involvement only of the colon. So this means that pentasa is used for Crohn's disease, not for ulcerative colitis, because you can treat, if Crohn's is affecting the stomach or the duodenum, you can still use pentasa. Then you have this very easy, again, alpha salicylic acid. This time they are calling it by the name itself. COL stands for colon, Asacol. These are all the brand names. It's used for ulcerative colitis. Rovasa, R stands for rectal. So rectum is always involved, as I said. Where is it involved? It's involved in ulcerative colitis. So you use Rovasa only if the most distal part is involved. You don't use it if the sigmoid is involved or the transverse colon is involved. You use Rovasa only for rectal ulcerative colitis. Sulfasalazine was another sulfa that was being used. It's not used because of too many side effects. Now, sometimes you need steroids because steroids also have anti-inflammatory effects, and they are used only if there are acute exacerbations of inflammatory bowel disease, something like what you do in asthma. But trust me, there are several acute exacerbations of IBD. Now, we are using a very uncommon steroid here. It's not the usual prednisone. It's not the usual dexamethasone. It's budesonide. And it's used per orally. It's very important that you use it per orally because it has to go into the gut. You don't want it to be injected intravenously, otherwise it won't go to the... So we want something which has only local GI effects. We don't want systemic effects of this budesonide. So you have to find some steroid which can be given per orally. It should also go through the liver and get detoxified, because budesonide otherwise can become toxic, and it cannot be inhaled. Now in asthma, you use exactly the same drug, but it is inhaled, not in this case. Azathioprine 6, mercaptopurine, again, these are anti-inflammatory drugs that are used in other conditions like rheumatoid arthritis and stuff. So in case you don't like to use steroids for some reason, you can go for azathioprine. And in very special cases, you can use a combination of ciprofloxacin and metronidazole only for distal Crohn's disease around the perirectal and perianal regions. So what this means is we are looking at fistulas and fissures. That's where you can use this. That also makes sense because metronidazole it will take care of the anaerobes. And we know that when you have perirectal leakages, you will get a lot of anaerobes around that region. Now, the most important problem, the biggest problem with Crohn's, and it's not a problem with ulcerative colitis, is the formation of fistula. Now, this is what you, even as a pathologist, should be able to spot. And that's because Crohn's disease is transmural. It can cause fistula tracts. It can go to the skin, bladder, or vagina. It presents as a painful, palpable mass. And for that, you have to give these monoclonal antibodies. So these monoclonal antibodies could be infliximab or adalimumab. These are basically, what is the mechanism of action? Can anybody tell me what is the mechanism of action of these two drugs? And we have already mentioned that it will seal the fistulas, which means it's going to be used for the treatment of Crohn disease, not for the treatment of ulcerative colitis. Now, these are TNF alpha inhibitors, tumor necrosis factor alpha inhibitors. So what is the point of using these? TNF alpha, what is the role in treating Crohn's disease. Now, TNF alpha is responsible for the formation of a granuloma. It holds a granuloma in place like a fortress. So the granuloma does not collapse. It does not disseminate because it is it is surrounded by a wall of TNF alpha in any granuloma, whether it's a tubercular granuloma, a sarcoid granuloma, or a Crohn granuloma. Take any granuloma, the wall is made up of TNF alpha. Take the example of, say, tuberculosis. And because of this wall made up of TNF alpha, the acid-fast bacilli cannot escape from the granuloma for several years. So if that patient, imagine a patient of tuberculosis who also develops a rheumatoid arthritis eventually and has to be given one of these TNF alpha inhibitors. Now, this is the mainstay for rheumatoid arthritis. It's commonly given. Infliximab is given, adalimumab is given. Now, when you give this, the fortress that now, if this is the granuloma and this is our TNF alpha, then this wall will break open. It will break. And what will come out? The acid-fast bacilli will spill out and it will disseminate throughout the blood. And what will happen? It will cause secondary tuberculosis. So it can cause reactivation of latent tuberculosis. So whenever you give infliximab or adalimumab, you should always do a PPD testing, a MON2 test, because you don't want to end up giving the patient tuberculosis. You try to treat Crohn disease and you give him tuberculosis. Not a good deal for the patient. Surgery, as I said, ulcerative colitis is completely curable by surgery. Just do a colectomy, get rid of the piece which is affected, and the patient is good to go home. But with Crohn's disease, it's not curable by surgery. Note this very important difference. Now, there are various good things and bad things about both the conditions. Ulcerative colitis can become malignant, although Crohn's can also become malignant. But Crohn's is not curable by surgery. It will recur. The more you do surgery, the more it will recur. Stricture is the only indication for surgery. In stricture means also obstruction. So this is the only indication for surgery in CD. Others, please don't recommend surgery in any such patient. If you look at the malignant potential, both of them can cause malignancy of the colon, provided they stay for more than 8 to 10 years. If somebody is diagnosed with ulcerative colitis or Crohn's disease and it's been just 3 years, then don't even think of malignancy yet, especially if it is ulcerative colitis. Get rid of the affected segment and the patient will be fine. So what you need to do is you should advise repeat diagnostic colonoscopy in such patients. The same is true if there are secondary complications of ulcerative colitis or Crohn's disease. If the duration is very prolonged, then it can cause CA colon. I'll try to wind up with a couple of quick questions which you will be able to answer very quickly. So we have a clinical study of adult patients with chronic bloody diarrhea. One of the patients is found to have antibodies to Saccharomyces cerevisiae, but not ANCA. Not two gene polymorphisms are seen. Then the patient also has vitamin K deficiency. See, somebody is already answering. Very good. I am very happy that you are paying attention. I don't want to even waste time trying to ask you what the answer is. The answer is going to be Crohn's disease. And again, because of the ileal involvement here, see, it becomes so easy once you know this. See, cerevisiae, start practicing that in front of your mirror. And not two genes. This is what they ask. So vitamin K and B12 deficiencies are plenty in such patients. And again, there is disrupted enterohepatic circulation of bile salts, so you get gallstones. The other options are useless except for UC, which is exactly the opposite, which is P-ANCA positive, but it is negative for Saccharomyces cerevisiae, and also similarly, nod 2 is absent. So that was question 1. This is the second one. So we have a 35-year-old woman. Now she has a very different story. She has arthritic pain. So we are talking of the extra intestinal manifestations. So she has arthritic pain involving knees, hips, wrists. Stool is positive for occult blood. Patient has sacroiliitis. Again, see, people have started answering. I'm so impressed. A colonoscopy is performed and a total colectomy is performed. You can do that here because I'm sure by now you have understood that this is going to be a case of ulcerative colitis. So again, I'm not going to wait for the answer. I'm seeing excellent responses from everybody. All of them are correct. Yes, all these answers are correct. So the correct answer is the development of Th2 immune responses. We have seen that this is true for ulcerative colitis. So this is a case of ulcerative colitis where you see Th2 immune responses. And it is well known for systemic disease, which is what I wanted to highlight: migratory polyarthritis, spondylitis, sclerosing cholangitis. Now, this is again an imbalance between T cell activation and regulation. The Th2 immune response has gone awry, which is why you get ulcerative colitis. Now, before I wind up, these are some charts that I put up for rapid review in case you're like one day away from your exam or something. Yeah, you can review these like in half a minute. I'll just tell you what. Now, these are the criteria given by the World Gastroenterology Organization. So these are the typical features of ulcerative colitis on this in this column, and these are the features of Crohn disease. You can see that discontinuous lesions, these are diffuse. Involvement of rectum is always there. Cobblestone appearance, everything that we have already seen. Fissures, granulomatous inflammation, and of course our friend anti-Saccharomyces cerevisiae. Is on this side we have ANCA. So remember these. This is one chart which was released by World Gastroenterology Organization. This is another one where I want to show you the differential diagnosis for this is the list of differential diagnosis. These are the main ones, the first part. And these are, don't worry about these. While as these are the main differential diagnosis for Crohn disease. Again, just before going to exam or while you're talking, discussing with friends, you can quickly review them. This takes less than a minute actually, if you do it well. And this, of course, also summarizes the importance of the treatment. I told you that we have these different types of 5 ASAs that can be used in different situations. Then we have steroids. We have other 6-mercaptopurines and stuff, and so on. So this is another. So you can also use methotrexate, again, another drug that is used for rheumatoid arthritis. So anti-TNF alpha is what I was telling you, very important. Infliximab, adalimumab, which can reactivate tuberculosis. Be very careful. This is why you should ask for a medication history when you come across a case of IBD. So what I'm trying to tell you is, see, they have actually mentioned infliximab and adalimumab here. Now, the reason why I have delved so much into the management as well is because we pathologists are no longer restricted to knowing just the pathophysiology and the histopathology features. We are expected to know everything about the disease. We have to know everything about the management, and we should know the side effects of the drugs, and we should be able to have an intelligent conversation with the clinician. So it's mandatory. Otherwise, the patient will come back to you after 10 months with tuberculosis and you will be lost. You will not understand why he has come back with tuberculosis. So I think that's it. Thanks for watching, everyone, and thanks for attending. So if you have questions, you can ask me. I can answer the questions. This time you'll have to open your sound and ask any questions. I want you to pay, I hope you have paid good attention to the histology. I have shown you plenty of images for each and every feature that can possibly exist. But besides that, if you have any questions, I'll be happy to answer them. And secondly, if you cannot recollect anything right now, you can still ask me on on WhatsApp or whatever. You can send me a direct message if you're too shy about asking right now. So Rahul is asking the histopathology features for early Crohn disease. It's very confusing. Early Crohn's or early ulcerative colitis, they can be very non-specific. They can be very confusing. They can be very non-specific. It may not be, you may not be actually able to diagnose early Crohn's. There are just too many confounding factors. Maybe the best bet is to look at some of these antibodies. If you have a very high index of suspicion, go and do the Saccharomyces study and do the P-ANCA and see if you can differentiate. Histopathology features take time. These are chronic diseases. These are idiopathic. So there is no possible way you can point to some previous illness and say that this could be Crohn's disease. The distribution also is very, very nebulous. As I said, it can affect everything from the mouth to the anus. So again, that confounds you. It need not have transmural impact straight away early on. It may be developing. It may take time to develop. All the features that we have discussed, the granulomas take time to develop. So early histopathologic features are a very, very big challenge. It's almost impossible, you can say. Unless there is yeah, I mean, early is very, there are no strictures, there's nothing to fall back on. It's hard. Even otherwise, it's hard. You don't get the cobblestone appearance so early. Nothing is in your favor at that time. The only thing that might work is maybe the inflammation in the mucosa. You can suggest that this is inflammatory colitis, indeterminate, undetermined, and then wait, ask for follow-ups. Any other question? That's it. I think we have run out of time as well. So let me finish the session. And very quickly, before I